where are we now? What's the most current? Where is the cutting edge technology and devices in anesthesia? Closed loop anesthesia delivery system, or CLADS. These are examples of a system. They work differently, but it takes inputs from the patient and it adjusts the anesthetic depth based on things like heart rate, uh, respiratory rate, the patient's blood pressure, the patient's electroencephalogram, which is like brain waves that we can measure with either a sticker on the forehead or the old school way is like tiny needles that go in the scalp. Um, so there's systems that we have developed that can measure these inputs and adjust the dose of an anesthetic based on these. There are none commercially available in the United States. There are some used in other countries, and they can be successful, not on their own, but being guided by an anesthesia provider. They can help to more tightly regulate the anesthetic depth. Um, so the thing is you need very reliable, reproducible data in order to make something like this to work, something that's some sort of automation. And if the patient has some issue or very acute change, it can throw one of these systems off. So we're not at the point where these are completely autonomous. They're okay. They're kind of like a cruise control in a car. So if you're on the highway, you put your car on cruise control and you don't have to mess with the gas pedal anymore. But you still have to be there in order to react to an accident or stop traffic. Same thing in a plane. Like pilots use autopilot all the time, but the plane is not going to 100% fly itself from takeoff to landing. So nice adjunct. It's cutting edge, and I think in the future we'll be using more and more of this. Ventilators, for instance, we could just set and say we want the carbon dioxide level to be this, and the ventilator can adjust the settings that are best for the patient in order to maintain that level. We don't use this currently at Penn, but the technology is available. There's also a score called the nociceptive level index, which takes in heart rate variability, um, photoplasmograph wave, which is like the pulse ox on the fingertip, and different other measures in order to determine how much pain is the patient having, and then the machine or the infusion pump can deliver it. As you can see, there's clear limitations because many patients have different variables. A 20-year-old healthy patient is going to have much different baseline than a patient who is older with multiple comorbid conditions. So here's an example. There was a system called Sedasis that Johnson & Johnson came out with in 2016. It delivered anesthesia to patients for when they were getting colonoscopies or endoscopies, where the patient gets sedated, they go in the colon with a scope, either through they can go like through the patient's rectum, look up their colon, and they could check for polyps, check for cancers. It's like a standard screening procedure when patients hit about 40 years old. Um, the thing is, the problem is patients became so accustomed to being nicely sedated, not remembering any of the procedures. This device couldn't safely sedate them to that level. It could only reduce the level of propofol, which is a drug that we commonly use for this. And patient satisfaction was very low. And there was no ability to rescue the patient if there was a problem if an anesthesia provider wasn't readily present. So very shortly after, Johnson & Johnson pulled it off the market and thought that it wasn't worth investing in to continue. So they may work better. So the clads that we talked about before work better for steady state anesthesia under general anesthesia, where we protect the patient's airway. We have breathing tube, we have everything nice and steady as a cruise control, rather than working as the full spectrum of sedating patients. We have some improvements of monitors. We have like a little fingertip cuff that can go on your finger. It's a blood pressure cuff, but it can actually measure your blood pressure continuously and give you a waveform, beat to beat. Again, the evidence behind that is not very strong. Most of the data says that it is not a great monitor compared to our standard of care, which is to actually put a tiny catheter into a patient's radial artery to measure the blood pressure beat to beat. Although the technology is there and it's hopefully improving to be used more in the future. We can more closely measure the patient's paralysis level with quantitative twitch monitors on their hands, so we know exactly how weak their muscles are. We have the ability to measure oxygen across the patient's forehead and their brain waves to kind of assess how deep they are under anesthesia and to make sure their brain is getting fed enough oxygen during like more dangerous procedures. There's different algorithms that can actually like warn a provider, hey, I think your patient's blood pressure is going to be low in the next couple minutes based on inputs of these monitors, rather than the provider having to rely on. We still monitor closely, but this is a nice adjunct that sees trends before we might see trends. There's telemedicine now where we might have a provider in a different, they could be in a different country, but usually in some different remote location, they have a bunch of monitors in front of them and they can come up on a screen. This is very commonly used in the intensive care units where the person in charge, usually an intensivist, it's like a physician who specializes in critical care, can pop up on a screen and direct everybody through like a code where the patient is crashing or something like that. They could be available 24/7, rural hospitals. This technology has been used for some time. Um, so anesthesia information management systems are getting much better. We get all of our information in one place, in it on a computer, and we're getting different hospitals to integrate. So if you need a study, one hospital to the next, usually it's available in the anesthesia system, the electronic health record. Back 10 years ago, you would need paper forms, and patients would have to come in with all their CDs, all their papers, all their results. And now it's all in one place. You can look it up within a couple minutes. Ultrasound, like we've talked about before, we're using that now for all kinds of things. We did a research project on our unit where we used it to place IVs, and an IV is like a catheter goes in your vein to give medicine, and arterial lines, which is like a catheter goes in your artery to measure your blood pressure carefully. Um, you can use this instead of just looking at a vein or looking or feeling for a pulse. You can actually visualize with the ultrasound to make sure you're exactly where you want to be. We can look at people's hearts rapidly with the ultrasound, check their lungs, check their stomach. And there's big advances in simulation. We have dummies. You can practice mannequins, I should say. We have mannequins that you can practice all kinds of procedures on that are realistic. You could put IVs in. You could do like regional anesthesia on a mannequin. It has fluids in it. It hooks up to a monitor, shows vital signs. And our medications are very safe overall, but they continue to get safer. Here's some pictures. Here's the telemedicine. Here's somebody sitting here in front of all these monitors, and they can pick up something emergently and pop in on the camera if they need. Here's an example of a sim lab. It looks just like an operating room, but we can train our students and our trainees with things that are very realistic. You can hook one of these ultrasound probes right up to your iPhone or Android or whatever you have nowadays, and do ultrasound taking your phone out of your pocket. Here's an example of like the brain waves, the electroencephalogram, where it processes it and just gives us a number. So instead of us needing to be neurologists and saying, oh, that's a delta wave, that's a beta wave, how deep is the patient? We just shoot for the number 40 to 60, and the algorithm actually does the calculation to give us that number. And so I just wanted to like highlight this quickly. So there's always conflict of interest, and I think this is like big for your club or group. Device companies and pharmaceutical companies have very, very different goals than do providers taking care of patients, nurses, x-ray techs, healthcare workers. We're sworn to some sort of oath that we're going to do what's best for our patients no matter what. Pharma and device companies are a business that need to provide income to shareholders. They have to follow the law and follow guidelines from the government, but they do not have the same degree of care. Some do, I'm sure, but it's a business. It's a business to earn money. They're going to provide products that earn them the most money and have the most success in general. So you always have to keep that in mind anytime you're implementing a new device or getting excited about a new device. So there's a thing called solution shopping where technology comes out before there's actually a use for it, or if there's even a need. So this happens oftentimes, and you have to really like weed this out when you're implementing new technologies. Smaller hospitals may implement things before academic institutions because they may just jump onto the newest thing, maybe get talked to by a device rep, where academia is a little slower to implement. We want to really make sure that it's going to change practice in a positive way and be cost effective. Um, so some providers might even find a threat to their purpose as things get more automated. So that's a big thing. Like obviously, I don't want my job to be gone if a robot's giving all anesthesia. So it's definitely something that I think you have to have the mindset. How can this improve our practice, and how can it free our attention and our time for more critical things? So you want to embrace technology and not look at it as a replacement for what you do. And psychology, economics, behavioral science, all these things come into play when you're implementing this, because you want to really get down to the ground. How are things going to work best with the providers who are using it at the patient bedside? So you always want to check if we run out. What time does your class go to, or this group go to? If we run over a couple minutes, I'm okay, but I'll just go through this real quick so we have time for any kind of questions. You always want to make sure things are evidence-based. Now, you'll learn more about this as you get into college, how to grade evidence and all that. So this is kind of a little advanced for now, but you really want to look at how were studies conducted, and is there any bias that is you need a study conducted that's not 100% funded by a company. How will it impact your patients compared to what you're doing now? And is it feasible to do this, and is it going to be cost effective? If it's not going to really improve care by much at all, but it's going to be much more expensive and much more difficult to do, then obviously you don't want to implement a new device or a new technology. And how can we keep looking at this? Just because you implement something new, you have to continuously evaluate: is this effective? Are things going well, or is this causing more problems? So you want to have a plan to assess how is it going when you implement something like this in your practice. Um, and you always have to look at risks. Is there any risk to the patient? If there's risks that outweigh the benefit, clearly we don't want to implement something. And you always want to balance. So whenever new things come out, there's always people who are very excited about it and want to implement it right away. And then there's people who are very resistant and want to just keep things the way it is. It's human nature to kind of resist change. But there are some people that are so excited with new technology, they want to jump on everything that's new. You have to like step back and take a critical view of everything. Try to look at it non-biased and say, is this good? Is it going to change care? Is it feasible? And does it actually have utility? So we just went through all this. But that's about all I have for you guys today. I tried to tailor this to you best I could. I hope it wasn't like too advanced, but hopefully you got a sense of like what's going on for technology with anesthesia. Here, I can cut sharing my screen here.
Thank you so much.
Yeah, absolutely. Do you guys have any questions, anything, curiosity? It doesn't even have to be related to this lecture, but if you're getting into medicine, you're interested in nursing, medical school, whatever, I'm happy to talk to you if anybody has anything they want to say.
We have one question in the back.
Go ahead.
Can you hear me?
Yeah, I can hear you.
Can you speak a little bit about the education it takes to get to be a nurse anesthesiologist or nurse anesthesiast?
Yeah. So, nurse, I guess technically the new definition is nurse anesthesiologist is but for the past 150 years, we called ourselves nurse anesthetists. So it's like kind of up in the air. But so the education is you have to have a bachelor's in nursing and get your registered nurse licensure, which is like a 4-year school. Some people, you could do accelerated bachelor's of nursing if you had a previous degree. Um, but yeah, it's usually 4 years of undergrad. Then you would get a job in an intensive care unit, somewhere where you're taking care of very sick patients. Um, and you have to work a minimum of 1 year in intensive care, and then you apply to graduate school. And then graduate school is a 3-year doctorate program. It's a doctor of nursing practice. Used to be a master's degree, so it was like 2 years of graduate school. So it's 7 years of college, the 1 year of experience in between, which you're working, you're earning money. Some people go back after 5, 10 years of experience. So it's not always people go right back to school. And usually like 2 to 3 years of experience is a good sweet spot. And then a lot of people go back to graduate school there. Whereas like an anesthesiologist is a physician. Everybody goes to the same pre-med. Well, you could do pre-med, bio, different undergrads, and then everybody does the same medical school, which is like 4 years of medical school. And then when you get out of medical school, you do an anesthesia residency, which is like 3 years. So the difference is our grad school is specifically anesthesia, whereas with physicians, their grad school is all the same, and then they go to a residency.
Thank you.
Yeah, no problem.
Any other questions? All right. I have a question.
Yeah, go for it.
Could you kind of like talk about what a day in your life looks like? Like what time you get up and like what time from when you get up to when you go to bed? So what does a typical day look like?
So what I try to, everybody's schedule is different. Some people work, I work one call shift a week, but let's say like a regular shift, I try to get up early. I have young kids, so I try to get up and exercise in the morning and before I go to work. So usually get up at like 4:45 or 5 o'clock. I'm on the road by 6 to get to the hospital around 6:30, 6:40. I set up my operating room, get the medications I need. I've looked up my patient. I know what they're getting done. If I have a few patients, I'll look up the other ones as well. Then once you're all set up, you have the medicine, you have your machine checked, you do all your safety checks. It's similar to like we liken it to the airline industry. You kind of like check your machine, you check your equipment for safety, and you follow like algorithms to make sure that everything's in working order for emergencies. Then we go out and meet our patients, usually put an IV in, talk to them, pre-op them, um, talk to them about the anesthesia, and either us or the anesthesiologist would get consent. It depends who's available and who's not busy. And then once the room's ready, we go get our patient again, bring them back to the operating room, sometimes give them a little relaxing medicine before we come back. Bring them in the room. We do safety checks again, make sure we're doing the right procedure, we're doing the right anesthetic. We look over the allergies one more time, and then we get the patient ready on the monitors and we get them off to sleep for the procedure. So, and then that would be something like, then we might put in a breathing tube just to protect their breathing for the case, put in other IVs or lines that we need to monitor. And then we say, okay, surgeon, you're good to go. You can start doing your portion. So, and then we like monitor the patient the entire case. So the surgeon does the operating, they do all the physical like cutting and all that stuff, and we maintain the patient's like whole physiological status. So we're making sure their vital signs, their blood pressure, if they need blood, if they need medicines, we're doing all that while the patient's asleep under anesthesia. And then when they're done, we wake the patient up, usually take out that breathing tube, and then make sure they're safe, everything's good, and we take them to recovery room where they stay until they recover from the anesthesia. And that's so we do that. Depends what some cases could be take all day. I've been in cases that took 18 hours, like for intricate brain surgery, or I've done 20 cases in one day when we're doing like very quick like injections in the spine, like for a pain doctor. So or endoscopy, colonoscopy, we'll do like 15 of those in a day. So they're all like 30 minutes a piece. So it could be very rapid turnover. So it's all different. And then when your day is over, usually it could be in the middle of a case, somebody comes and relieves you, and you do a safety handoff, and that person takes over the care of the patient. Or if you're there on call all night, you just stay throughout the night in case there's emergencies. But not all places you have to do that. It just depends what you decide to do.
All right, thank you.
There's definitely it's a kind of profession where you have to keep up with your education. There's standard continuing education that you do, but it's the practice is ever changing. So we do lectures at work, we have classes ourselves, we make sure we stay up to date and doing what's right for our patients.
Thank you. Any other questions?
Absolutely. And if you think of something, you can always talk to David. He can shoot me an email or something. I'm happy to answer questions. If you guys are actually interested in CRNA school or interested in something of this nature, you had more questions, you could reach out. I'm happy to give you some info.
Any other questions? Anything? All right, I have one more question. If you don't mind.
Oh, yeah, yeah, go ahead.
Would you say, was it worth it? Was it worth
Yeah,
the education
I would-
and all that time to be where you are today?
I definitely would say yes.
What
I mean,
advice would you give to high school students that are like interested in possibly pursuing this field or just healthcare in general, I guess?
I would say I think there's a lot of good places to go in healthcare. I'm very happy with the nurse anesthetist route. It's not something that's super well known, but it's been around a very long time. And as far as advanced practice nursing goes, I think it's a good career. Um, you shouldn't get into anything for compensation, but the compensation and the salary is very good and competitive, probably the highest out of all advanced practice providers. But it's also can be a very high stress job, and you train. That's why you train so many years and you go through rigorous training. Graduate school is like pretty intense. You're doing like 40 hours a week plus in the hospital, so working in your residency, plus you're doing like a full class load. So when you go to college, you'll see how things are in undergrad, but it's very busy, but it goes by fast. And if you're dedicated and you study hard and you just get your work done when you need to, it's well worth it. I think, and healthcare is very rewarding. There's times that are emotionally difficult, obviously, like you're gonna have challenging, especially if you take care of sicker patients. Like you can't always help everybody, and you always do your best, but it's a very rewarding career. The people you help, the things you learn, especially if you're into sciences, chemistry, pharmacology, like nurse anesthetist is a great career, and I'm definitely happy with what I did. And there's many other good careers too. So I'd encourage you to shadow, get an idea of what different people do, and ask as many questions as you can, and then you can determine what you want to do.